So currently, what are some unmet needs in liver cancer is that we have a lot of treatment options that has come up. Now, I think just like the questions that was raised previously, how do we sequence the current therapies? Do we use sorafenib first because second line options are for sorafenib failures? Do we use lenvatinib? Do you use checkpoint inhibitors in second line setting, or do you continue TKIs? So I think the sequencing question becomes important. How do we sequence currently effective liver cancer patients is one crucial question we have. The second question, I think the second area of unmet need for my patient population is that most of the current studies are done in Child-Pugh patient population. So these are patients with good liver function. And I have seen, in my practice, about 30 to 40% of my patients actually come in Child-Pugh and C patients. And unfortunately, not many studies, except for nivolumab in Child-Pugh 7 patients, all other studies are done in Child-Pugh 5 and 6 patient population. So I think another area of unmet need is how can we manage those patients with poor liver function? And those Child-Pugh patients. I think Child-Pugh C we discussed about hospice and palliative care, but I think in people with moderate liver dysfunction, how do we manage those patients? So I think some critical unmet needs are: do we need to conduct clinical trials in patients with Child-Pugh liver dysfunction? And also, how do we sequence currently effective agents? And how do we do clinical trials in other pathways and things? So I think there is a lot of science and a lot of progress that also still need to be met in patients with liver cancer. Now, we are conducting a lot of clinical trials of adding immune checkpoint inhibitors in the earlier setting. So patient after resection, I think we are looking at checkpoint inhibitors, if those will be effective in high-risk patient population. We are also doing currently clinical trials looking at checkpoint inhibitors after local regional therapy, like after TACE and regioembolization. So I think those data will be emerging and trying to use systemic therapies earlier on in the adjuvant setting, as well as in the locally advanced setting. But we also have to answer questions for patients with more poor liver reserve, and how do we manage those patients?
Those patients usually the dynamic CT or EOD MRI finding a difference. So in that case, we perform PET CT. PET CT is useful to diagnose a poorly differentiated HCC non-invasively, and the lenvatinib is very effective for poorly differentiated HCC. So we use lenvatinib preferably and for poorly differentiated HCC, PET positive HCC. But of course, lenvatinib is not perfect. So the very aggressive tumor is for those HCCs, we need other combination strategy, like PD-1, PD-L1 antibody plus anti-VEGF agent.
It's diluting a lot along those lines. So the problem in hepatocellular carcinoma patients is that the underlying cirrhosis is typically over time deteriorating, and it is not just the tumor which is defining treatment options, but it's mostly, in fact, liver function. So we probably only see in the sequence of one to the other line about this is what has been demonstrated by observational trials, that roughly a quarter only makes it from one line to the other.
It was quite striking to see, I think, from the Checkmate 459 trial that around half of patients after first line went on to receive a second line regimen. And likewise from the from the Keynote 240 trial in the second line, also nearly half of patients went on to receive a third line regimen. And so this is telling us that a subset of patients across lines of therapy are doing quite well and are able to try multiple approaches and to determine which is the most effective for their cancer. And in some cases, this will allow us to proceed with third-line therapy. And I would add, this is not an insubstantial number. I think this is a meaningful proportion of patients will go on to receive third-line therapies. What that means is that we need to better identify how to sequence therapies, particularly with the rapid changes in the frontline setting, and to do our best using pooled analyses and retrospective analyses of patients who receive downstream therapies on clinical trials, as well as large real-world databases to the extent that they exist, to define the optimal approach in the later line space. Ideally, we will have prospective trials to help guide choice of therapy. These, however, will certainly take a long time and may not be feasible for every possible, certainly won't be feasible for every possible clinical question that we face. So therefore, again, I do think that it's important to perform pooled and retrospective analyses, as well as look to the real-world data sets when available.
In the United States, the checkpoint inhibitor monotherapy is approved, like nivolumab and pembrolizumab. But in Japan, those two are not approved yet. So we are waiting for atezolizumab plus bevacizumab approval. It was positive in Brave 150 trial was positive and published in New England Journal in Medicine recently. So it will be approved in Japan maybe this year. So the first line option of the first line option will be the atezo-bev combination therapy. But after that, we select the multikinase inhibitor like sorafenib or lenvatinib, because there is a report that the PD-1 antibody bind to a CD8 positive T cell more than 20 months, which means even though progressive disease after immunotherapy, switching to the targeted multikinase targeted agents like lenvatinib, sorafenib, provided a very favorable situation that lenvatinib or sorafenib will kill the tumor cell and will change the tumor microenvironment from tumor suppressive to tumor permissive. In that sense, for 20 months, there is that multikinase inhibitor provides the same situation with the combination therapy with immunotherapy plus TKI. So sequencing is similar after immunotherapy. In front line, maybe atezo-bev therapy, then first line agent like lenvatinib, sorafenib, then ramucirumab or regorafenib or cabozantinib. So, and also the lenvatinib is also can be used as I said, third line or fourth line. It is good. It provides good response.
My first hope is that we can identify a biomarker of response to immune checkpoint inhibition as monotherapy. I think the fact that there is a reproducible number of patients who have deep and durable benefit from drugs like nivolumab, pembrolizumab, and even atezolizumab, if we look at the phase 1b studies leading to the atezo-bev regimen, immune checkpoint inhibitors as monotherapy have about 15 to 20% of patients can achieve a robust immune response. And I hope that there is a way to identify those patients, because it will help to guide treatment sequencing, whether patients need an upfront combination or whether they could have this deep and durable benefit from a monotherapy PD-1 or PD-L1 inhibitor alone. What that biomarker will be remains elusive right now. There is certainly a trend in many of these studies towards improved outcomes with higher PD-L1 expression on tumor. but no one study has yet shown a significant result, owing in part to small sample sizes and underpowering with respect to the biomarker question due to, again, small sample or perhaps an overall negative study endpoint. There are other potential candidate biomarkers such as immune infiltration or immune class gene signatures. Those are more complicated to scale as a biomarker across a larger population. But again, I think that we can look to data from other tumor types, and it may be possible, at least based on the reproducible proportion of patients with a very clear-cut benefit. I hope there will be a monotherapy biomarker in the future. Beyond a biomarker to define that population of patients likely to benefit from monotherapy, I see the treatment landscape evolving to include nuanced choice of combination regimens in the front line according to patient factors, tumor factors, and maybe a biomarker. And then hopefully we will be able to develop wise and approaches to choice of therapy in the second and third line using pooled and retrospective analyses to guide the sequence of therapy downstream.